and I'm here with HIT 340 Comparative Records. We are now on Chapter 4, which is week 4 for us, and it's all about managed care. There is managed care in the acute world, there's managed care in the ambulatory world, and basically there's managed care everywhere you can possibly imagine. So let's talk about what does that mean for comparative records. All right, the learning objectives here are pretty similar to what you have in the syllabus. If you're looking at your syllabus, you would want to be looking at course objective 8.9, which is unit objectives 9.9.1 through 9.9.8, and that is on page 5 of your syllabus at the top. We want to be able to describe the characteristics of a managed care organization, talk about the relationship between managed care and coordination of benefits, define PMPM, per member per month, and its purpose in managed care, explain the differences between coinsurance and copayment, differentiate between the different management formats of HMOs, identify the agencies that accredit managed care organizations, define the purpose of HEDIS measures in the delivery of managed care services in a designated health plan, and identify the use and purpose of the secondary data elements that are collected in HEDIS measures. So this is going to go through the learning objectives for the book, and like I said, they're pretty similar to ours, so we'll move through those pretty quickly. It's really just understanding managed care. HEDIS measures are healthcare effectiveness data and information set. And one of your activities will be going out and looking at HEDIS measures. So I think that's part of your discussion for this week. You will become very familiar with HEDIS measures before you finish the program. And then, of course, the consumer-directed health plans and utilization management. So, settings and plans. There are HMOs, PPOs, POSs, managed indemnity plans, consumer-directed health plans, and IDSs. Lovely. Here in the U.S., we have choices, which is not a bad thing. It just is. Makes it a little bit more challenging to learn, but we can do it. So, what does a health maintenance organization do? They arrange for or provide health services to enrollees. The enrollees pay a premium, and the premium is a prepayment for services. There is an incentive for the enrollee to participate in preventative care, and there's an incentive for the care provider to provide the most efficient possible care. HMOs typically provide health care in a specific geographic area. That may be a region, that may be a state, that may be, it can range anything over several counties to a state, to several states, to a certain part of the United States. It's an agreed upon set of basic and supplemental health maintenance and treatment services, and the people who enroll in these do it voluntarily. This is a choice. There are different types of HMOs. There's a staff model, a group model, a network model, an independent practice association model, and a mixed model. And your book will go through these, so I would definitely make sure you read through your textbook for all of this. There are also different types of managed care called PPOs, POSs, and the managed indemnity plans. Let me go back to that. Those are similar but with different twists, but those are different types of managed care, but very similar to HMOs. When you talk about consumer-directed health plans, that's what's really become the big rage these days in terms of employers and employment, is setting up flexible spending accounts or health reimbursement arrangements, health saving accounts, high deductible plans. You might have heard of that, where you have a high deductible that you pay for, and then there's a health savings account associated with that. The flexible spending accounts, FSAs, are different than HSAs. FSAs are something you can set up through your employer, and they're usually limited right now to $2,800 a year. They'll pull that out pre-tax, and then you have to use it or lose it by the end of the year. And you can use it for things such as eyeglasses and prescriptions, anything that you would pay out of pocket for that's a designated medical, dental, visual, auditory type situation that has to do with health care or health. And then you get reimbursed for it out of the flexible spending account. Whereas a health savings account, that's money that's set aside and it's there to help you pay for your high deductible plan. So it's a little bit different. Types of patients. You can have members who are subscribers and dependents, families, insured units, contracts, and the type of patient varies from facility to facility. Types of caregivers. You will definitely be involved with physicians, physician assistants, and nurse practitioners, those providers that are actually providing the care. And then a lot of these programs, managed care programs, have a wellness coordinator or a health educator, and or both, who are trying to help you improve your health and minimize your need for healthcare services. So what are some regulatory issues with managed care? The government is involved. Medicare Advantage is an HMO managed care type of situation. There is a Medicare managed care manual. There are CLIA rules, Clinical Lab Improvement Amendments, that have some impact on this. And then there's state regulations. Each state's insurance commissioner can be involved, and there might be other HMO regulatory agencies that come in and monitor things or mandate certain things with managed care. Managed care companies can be voluntarily accredited. NCQA, National Committee for Quality Assurance, has some standards for managed care accreditation. Joint Commission, of course, does as well. AAHC, the Accreditation Association for Ambulatory Healthcare, also looks at managed care, and so does URAC. So there are those four bodies that can provide accreditation to managed care companies or organizations, but accreditation for managed care is entirely voluntary. They don't have to do it. Managed care, how do they generate revenue? It comes from selling that insurance product and then being able to provide quality health care to the member and improving the members' efficiency in accessing health care. So yes, the revenue comes in from what patients pay to be a part of the managed care organization, and then what the managed care organization then turns around and pays or reimburses the providers is supposed to be revenue as well, that essentially they get more from the members than what they pay, is the risk that they take on. And the providers as well, because if you stop and think about it, the providers are given a set amount, and if they provide more health care than that, they may not get reimbursed. So it's a risk situation. So you get the premium payments. The premium is determined by community rating, and of course the risk of each person for what kind of healthcare services they might need. And premium rates can be structured to be a lower amount if the patient is willing to make co-payments for different types of care. There are ways that they reimburse providers. They may actually pay the provider a salary and the provider only sees HMO patients. They may have a capitation agreement where they pay a per member per month amount to the provider. And that's all the provider gets. So if they see that member more times per month, the provider is the one who loses the money. And it's a set amount for the managed care organization. They may pay per diem. For instance, if they contract with a hospital to provide care, they may just say, we're only going to pay $2,000 a day, something like that. Maybe in a behavioral health or substance abuse treatment setting, and that might be the case. Maybe in a nursing home setting, home health, hospice, those might be per diem type things. They have negotiated fee schedules. They sometimes pay RB/RVS, but again, that's really going away because Medicare and Medicaid have moved farther and farther away from RB/RVS. They may pay on a fee schedule based on the percentage of Medicare patients that they're treating. Typically, the older the patient is, which is more Medicare age, the more services they need and the more cost they will be to the managed care organization. And so you may see that if a provider has a higher percentage of Medicare, their fee schedule may be reimbursed greater than someone who may have a younger patient population. Then there's diagnosis-related groups, DRGs, for hospital stays, where they basically pay one lump sum based on the DRG, regardless of how long the patient stays. And then they may do what's called discounted charge, that maybe they'll pay 80% of the charge, or maybe they'll only pay 50% of the charge, or maybe they'll only pay $10 for every $30 that they're charged. Those types of things. They get a discount. So moving on, coordination of benefits. They have to know who the primary insurance payer is and assuring that no more than 100% of the charges are paid to the provider or reimbursed to the patient. That's the coordination of benefits. A lot of times patients have multiple insurance coverages. Maybe this is a workers' comp situation. Maybe it's a motor vehicle accident or a personal injury case. Who's all involved and who pays first? And what do they pay and what's left over, and then who pays next? That's all called coordination of benefits and coverage. So in terms of information management systems, obviously there's the billing one, because they've got to be able to keep track of who's paying and what they're paying and how they're paying. But backing up before that is coding and classification systems. They're using ICD-10-CM for diagnoses. ICD-10-CM is used for all settings for diagnosis codes. Then they're using CPT, HCPCS codes sometimes, for physician services. All physician services, even those in the hospital. They use CPT and HCPCS codes for facility claims for non-inpatient services. So if you are an inpatient and you have a procedure and you have an inpatient procedure, they're going to use ICD-10-CM for your diagnosis codes, and they're going to use ICD-10-PCS for your inpatient procedures. But let's say you go into the hospital and you are brought in as an observation patient, which is not an inpatient status. Well, then you're not inpatient. You're still going to have ICD-10-CM diagnosis codes, but you're going to have CPT or HCPCS, or as it's appropriate, HCPCS codes for the facility for those non-inpatient services. And then, of course, the physician services will all be CPT, HCPCS, and they'll use ICD-10-CM diagnosis codes. When would they use special uses of coded data? Well, we talked a little bit about risk adjustment. And if we didn't talk about it here, we're going to be talking about it in many of your other second year classes. So if you're not familiar with HCCs, please take a look at that, but it should be in your book. We should have talked about it already in one of your classes. If we haven't, we will soon. HCCs are called hierarchical condition categories. These were developed by Medicare, of course, and Medicare developed them because they were trying to predict payment for the next year for their patients to try and control spiraling costs. So let's take a pretend patient. Let's say that I am 67 years old, which I'm not, by the way. I am not anywhere near there. But if I were 67 years old and I went to the doctor and they looked at me, and let's just pretend that maybe I had COPD. I don't, by the way, but if I did, they noticed that I had COPD and I had an inhaler and occasionally I needed nebulizer treatments and who knows what else. When they code out my chart in that office, in the provider's office, they need to make sure that they put down that COPD, not just shortness of breath, not just emphysema or whatever other kind of COPD, but really noted the COPD and the fact that maybe it's a chronic condition. And so to check my COPD, I need to come back every 2 to 3 months to be checked by the doctor because they're trying to prevent an exacerbation of COPD that could end up with me in the hospital. That chronic condition of COPD, which has been established in the office and I'm on medication for and being treated for and that sort of thing, is an HCC. It has a higher weight than if the doctor says, oh, I've been in 3 times with shortness of breath. And so what they do is they identify all these HCCs and they weight them and they roll them up together. I mean, you could have multiple HCCs depending on the complexity of the patient. And they figure out basically from that, how sick are you and how many resources or visits are you going to need based on last year in the coming year. And then they assign an amount. And this is where you can see where coding is so critical in the managed care world. If you don't have documentation to support your coding and you don't code to the highest specificity, you may not be able to trip the triggers electronically for these HCCs. And so when they're calculating how much they're going to pay your provider next year for this patient, your patient may not be paid what they need to be paid, justified based on their conditions for how they're going to be treated next year. So that's why HCCs have become so critical. They were developed by Medicare, implemented by Medicare and Medicaid, and now the managed care groups and organizations have jumped on the bandwagon because they see the benefit of being able to say, oh, if you have 1 HCC, here's what we're going to do. If you have 2 HCCs, here's what we're going to do. If you have 3 HCCs, here's what we're going to do. And they can basically establish, okay, here's how much we're going to pay you for this person for the next year. And so they can add that up and say, and plan ahead, here's what we expect of our members. Now, the unfortunate part is sometimes they only do that on 9 months of data from the year. So if you have somebody who's terribly healthy the first 9 months of the year and they go to gather the data there, and then they're very sick at the end of the year, they may not pick that up. And your reimbursement may not reflect that until the following year when it all catches up. And then, of course, they're looking at those DRGs, those diagnosis-related groups from inpatient hospitalizations to see what's going on there. And, of course, you know from your classes with Miss Shelley Grant about your CCs and MCCs, how critical those are, and making sure there's documentation to support those and that those are correctly identified. And then you have UB04 revenue codes that are also reported. So data and information flow. You definitely have data collection and you have data transfer. You have the encounter data, you have referral data, you have claims data, all of those types of things. You have statistical data. The number of members in each managed care organization each month, how frequently are they coming in, and what are the number of contracts for the month. So looking at electronic information systems, what do they offer to managed care services? Well, that's the way they track their eligibility and enrollment. If any of you have worked as a registrar or, excuse me, in registration at a healthcare organizational setting, you know you have to check the person's insurance, their eligibility, their enrollment. And with Medicaid, you have to check it on a monthly basis. Then there's benefit levels, understanding, no two differently insured people have the same benefit level usually. They have different ones. And the benefit levels can change. So you have to keep checking on that. Registration and scheduling, making sure you have accurate home address, that you have accurate contact information, that you have the basic identifying pieces of information, and scheduling. How often are they coming in? Are they following through on their appointments? Are they a no-show? Authorization and referral management. You have to have a place to keep that you've got authorizations to be able to do certain procedures or tests, or that you had approval from a case management standpoint that you were certified for three days of hospitalization, or that you had an add-on for the 4th day, those types of things. Information systems keep track of billing and claims production. Obviously, that includes coding as well as charge types things. It keeps track of payment and claims processing, cost accounting. How much is it costing to administer the program? Where's the money going? Is it going, which providers is it going to? And how many members does that involve? And which product, which managed care product is that under? And then you have your EHR and your executive decision making. Data sets. Here we get into HEDIS measures. You will hear about HEDIS measures lots, and not just in this program, but if you get out into the world and you are dealing with managed care or physician practices or provider practices, clinics, outpatient clinics, those types of things. HEDIS measures have grown to become absolutely mandatory. There are a core set of performance measures. They were developed by NCQA, and you can go out to the website and take a look at those. And they judge the provider based on how they are following these HEDIS measures. That's the way that they measure quality. That's the way they measure effectiveness of the provider. And then there are employer-specific data sets that they also gather information on and review, and that they may require certain things. And HEDIS is an aspect of quality improvement. They want to see that, let's take influenza immunizations in the elderly population. They want to see that providers are at least trying to get the elderly in their population to have influenza vaccinations to prevent possibly getting flu down the road and ending up being hospitalized. And to them, that's a quality indicator. That is a way to see that they are caring for their patients. Mammograms would be another one, making sure that they get mammograms. Colonoscopies after the age of 50 is another HEDIS measure. And I can go on because there's tons of them, and it's really worth going out and looking at those. So quality indicators include HEDIS measures, but they are more than that. There are operational quality indicators, how well certain organizational goals are being met, medical in terms of how are patient outcomes doing. Do you have more that are getting these screening exams? Is that causing you to have less earlier diagnoses of different kinds of cancer, or fewer, or what is that? And then financial. Are you utilizing your resources more efficiently and effectively? Are you managing your patients so that they're having fewer hospitalizations, fewer emergency department visits? Maybe you're managing them through a phone call case management process where you're checking in with them several times a week, so that if they do start deteriorating, you get them right into the office and can deal with it before they end up needing to be hospitalized. And then AHRQ has lots of tools to help with quality improvement. So utilization management, what does that include? It includes pre-admission certification, which is just what it sounds like. You have to be you have to be certified if you are having an elective procedure to be pre-admitted. Make sure you've got that. Pre-admission and pre-authorization are essentially the same thing, but pre-admission is for the hospital setting, inpatient hospital setting. Pre-authorization is for a test or treatment that might be, for instance, a PET scan would be an example that you've got to get pre-authorization for a PET scan. Those are very expensive, and you have to meet the criteria that is required before you can get a PET scan. Otherwise, they won't be the payer will not pay it, and the hospital or the healthcare organization will be left with a huge bill that they're going to have to write off or absorb. Concurrent review is done, where every day they're checking the chart, they're looking to see what's going on, what has been added, what has been changed. Is the patient doing better? Are they looking like they're getting closer to discharge? Have they developed a new condition? And is it going to result in needing to be hospitalized a little bit longer? And that's all those types of things. And then utilization protocols and coordination of care, including discharge planning. From the time someone's admitted, the first question becomes, when do we think this patient's going to be discharged? And what needs to happen between now and then to make it a successful discharge? For instance, does this person have support at home? Is this person capable of caring for themselves? Are they going to need some kind of additional service, or are they going to need skilled nursing care? Those are all parts of what goes into it. Risk management and legal issues. Risk management and legal issues are about identifying unusual events and trying to prevent those, but also when you get them, how do you manage them? How do you mitigate them? And try and minimize the impact to the patient as well as the organization. Informed consent for procedures, making sure that before we perform a procedure on a patient, we know that we have informed consent to do so, meaning that we've gone through with them the risks, benefits, alternatives to having the procedure. What does the procedure include? What does it not include? What would happen if something would go wrong during the procedure? What happens if we open a patient up and we find something more significant than what we anticipated? What happens if we get in there and find we can't perform the procedure for whatever reason and we're going to have to back out? All of this has to go into informed consent. And we have to make sure that the patient is competent to understand these things and be able to give their informed consent. Otherwise, you are committing battery against a patient, which is a legal crime. Credentialing, making sure that the provider is licensed, educated, trained, credentialed, privileged to be able to do what we are permitting them to do. And that's looking at their documentation, looking at the procedures they've performed, all sorts of things. And it can be going to the office and doing some kind of evaluation, whether it's structured or record review. It can be looking at them economically and whether or not you're going to re-credential. And then there's contract management. Looking at your contracts. Are your contracts fair and equitable? Are there inappropriate incentives on either side in there? Do you have business associate agreements for HIPAA compliance? All of that. So what is the role of the health information manager? Well, there are plenty of roles in managed care. You can be involved in developing and implementing the information plan and the IT part of life. There are also specialized functions, being involved in enrollment management, claims processing, quality management, performance improvement, risk management. There are even HIM folks that are that grow to be a chief information officer in these organizations. It's few and far between, but they do have plenty of room in managed care for services that we can provide, that we are trained to look at, understand, and perform. So some trends. Integrated delivery systems and networks. If you're not familiar with those, please take a look in your book as well as online. There's constant change in the role of all physicians, but the primary care physician is really changing from that country doctor perspective into something greater, and something different, more specific. So that might be something you want to research. Possible changes in federal programs are constant. Federal programs never stay the same, ever, ever, ever. They change every year. And then accountable care organizations are a relatively new trend. Most of those were developed about 5 to 7 years ago. And so really they're getting kind of no longer a new trend. Most of those that have been that were going to be established have been established, and you can go out and take a look at those as well. So in summaries, managed care organizations continue to change. They do an enormous amount with quality improvement and data management, and there are lots of employment opportunities for HIM professionals. Now, I will caution you a bit that sometimes managed care companies think they need a nurse. And we have training in anatomy, physiology, pathophysiology, pharmacology, medical terminology, so many other areas that are shared with nurses. We have a 2-year degree. Most nurses have a 2-year degree. And yes, we may not be hands-on with patient care, but we definitely have a great base of knowledge. We get into the IT systems and some of the regulatory aspects much more than a nursing program would. And so those are valuable talents and commodities that we can bring to the table. So again, it encourages you to go to the NCQA website and talk about and learn about HEDIS measures, and then just finishes with the last question. So this was Chapter 4, all about managed care, and I will be back next week for week 5 to talk to you about dialysis and Chapter 6, correctional facilities. So week 5 we'll be doing 2 chapters. Take care and have a great week. Bye.